Dr. David Waterhouse, can you please take us through the most important parts of your presentations here today?
Thank you for giving me the opportunity to do this. The most important piece of this is relative to the trial is that the patient-reported outcomes and the improvement in their outcomes supported the approval of sotorasib as a first-in-class inhibitor of KRAS-mutated G12C mutation patients with non-small cell lung cancer. So what we see here is the importance of the patient perspective, not just the investigators. I may see that a cancer shrinks, but at what cost to the patient? Was the treatment worse than the disease? Or conversely, did shrinking their cancer and improving their progression-free survival result in a better living experience? And what we saw here was pretty significant. We saw that if they were randomized to this sotorasib arm, their quality of life was maintained over time, whereas if they randomized to the docetaxel arm, the toxicities of docetaxel not only were measurably greater, they resulted in a negative patient experience and a diminished quality of life. So in the context of this clinical trial, that's important, and it supported the approval of the drug across multiple countries. More importantly is that this was a very good demonstration of the importance of capturing patient-reported outcomes and looking at what toxicity does to our patients through their lens and not mine. I may say that a person has grade 3 diarrhea, grade 2 headache, but I can't say how that impacted the patient. Some patients may breeze right through it, no problem. Other patients may be greatly impacted by this. The incorporation of patient-reported outcomes allows us to understand what not only did our treatment work, but at what cost to that patient. In other words, was it worth it? And I think that's a question that's been asked oncologists repeatedly since we started doing this, and certainly in lung cancer. This is how oncologists got a bad name, was our original lung cancer treatments were in fact worse than the disease.
You said that you were in the starting phase of using patient-reported outcomes. How do you think we will use them going forward into trials in a better way?
Okay, they have been around for probably close to 10 years. It has become fashionable to incorporate them in trials in some way, shape, or form. Not necessarily as scientifically embedded as they were here, but in every trial you're now seeing them. In the future, though, I think we're going to see them are more important. They will help support regulatory approval, and their lack of being reported will actually inhibit regulatory approval. I actually believe that they will supplement, if not replace, investigator assessments for early grade toxicity. As I mentioned in the talk, investigators are not very good at assessing low-grade toxicities. Why? Because for us, for giving the treatment, it's not as important. It should be, but it's not. I want to know, can I give you the drug, yes or no? But when a patient has to decide if they're going to take it, yes or no, because it's an oral drug and it's in their medicine cabinet, they get to decide. And they're going to decide based on their experience. And so my letting them report this as opposed to my assessment, I think is actually more valuable. I'd like to see patient-reported outcomes replace my assessment, at least for early grade toxicity, and be supportive and supplement higher grade toxicity. And I think we're going to see that.
What's the most important thing you have learned about how to use patient-reported outcomes for future studies, maybe for yourself, but others also? What should they learn about this study in future studies?
I think we're not done yet. And so my plea to other investigators and young investigators is this is a place where they can make a great impact, not just for any one trial, but across multiple diseases and trials. So get on it and do it and make a science of it, get better at it. To me, that's really important.